to Shannon Veronica Know Everything. Today we're going to be going over migraine treatment. So we broke it into acute treatment, and then we also have prophylactic treatment. So to begin with acute treatment, we have analgesics and NSAIDs. So for analgesics, that's like your acetaminophen. And typically these aren't really used in regards to acute treatment for migraines. More so you're going to find that it's recommended to use an NSAID, so like aspirin, ibuprofen. And then after that we have combo analgesics. So for example, you might have heard of Excedrin migraine. So that's a really good option to give to your patients in regards to just using an acute treatment that's over the counter. Now moving over to things that are prescribed. So we have ergots. So these are a non-selective serotonin agonist in comparison to our triptans, which we're not specific if it's selective or non-selective. All we know that it is a serotonin receptor agonist. So DHE is the one that you need to know. Dihydroergotamine. So if you see that in the exam, that's ergots. One big drug-drug interaction is with triptans. So if you have a patient who's on a triptan, it's not working and they want to move over to an ergot, so you have to give at least 24 hours before they actually administer the ergot to the patient. So some precautions. The big thing is uncontrolled hypertension and then any type of heart disease. You also want to know that gangrenous extremities is one of the major serious ones. So I remember this as like ergot is like a monster who's gangrenous, so he's like a big green monster. And then nausea and vomiting is really common with this, so you also want to provide an antiemetic to treat that nausea and vomiting with the ergots. So now moving over to triptans. So as mentioned, these are serotonin receptor agonists. And there are quite a few names here, just because they all end in triptan, so that's the way you can differentiate whether it's a triptan or not. A few we want to mention is Frova and Noratriptan. So these are slow releasing, so they have a long half-life. So thanks to Shannon, we have a great mnemonic for this. You just remember effing long half-life. So like fucking half-life, that's long. So F for Frova and Nara. These also have the least side effects in comparison to the rest. So that's something to note. Suma is going to be your fastest, so it's going to work the quickest. And he said it's also sub-Q. And then as far as administration, I believe that they all have like nasal and sub-Q and
they all have various routes of
oral,
administration.
Yeah, various routes of administration. As far as drug-drug interactions, so SSRI, as you mentioned, the ergots, and then many OI medications. So with these, you can repeat the dose. So you can do it after 2 hours with a few exceptions. So Nara, it's 4 hours. So I kind of think of like Nora, like a person, like she has to wait 4 hours in order to take the medication again. And then if you use sub-Q, it's just 1 hour. So that's something to keep in mind. You should limit the use to about 2 to 3 days per week. If you find that your patient's using the med more often, you want to consider a prophylactic treatment at that point. So now we're going to move over to prophylactic options. So indication is going to be if your patient's having 2 or more migraines per week, or if they're not getting any relief from using symptomatic treatment, or if they have really bad side effects with those options. Another thing will be your patient preference to limit that migraine. So if your patient comes in and they're just like, it's continuous, I really just want to try to get it before it even occurs, then that's when you would consider prophylactic. So for prophylactic, we have beta blockers, we have antiepileptics or anticonvulsants, and then we also have antidepressants. So to go over beta blockers, a way to remember this, again, thanks to Shannon. We have toilet paper in the morning.
I don't want credit.
TPM. So timolol, propranolol, and metoprolol. So the TMP, the first two, just remember that those are FDA approved for migraine treatment. Now moving over to our anticonvulsants or antiepileptics, we have topiramate and then valproic acid. So just remember they're kind of like at the end of the alphabet. And then antidepressants, we have a tricyclic, which is amitriptyline, and then we also have an SNRI, which is venlafaxine. Just a few FYIs, when it comes to prophylactic, there's actually something new on the market, and it's called a GRP antagonist. So this is a once-a-month injection that you can go in and get. And then we also have Botox. So typically Botox is used for people who have chronic migraines. A chronic migraine is defined by 15 or more migraines per month. Just to go over treatment, we have the acute treatment, which includes your analgesics, your NSAIDs, your ergots, and your triptans. And then we have prophylactic, which is your antidepressants and your convulsants, and then your beta blockers. So thanks for tuning in today.